Uh, this is my case for today's Thursday clinic. A 5-year-old, a 4-month-old female child, first by birth order, born out of non-consanguineous marriage, was brought by father, came with complaints of fever since 12 days, loose stool since 7 days, and vomiting also since 7 days. Patient was apparently well prior to the onset of symptoms when she had fever, which was undocumented, high grade, not associated with chills, rigors, or rash, loose stools, which was 7 to 8 episodes each day, yellowish in color, watery to semi solid in consistency. Vomiting was 2 to 3 episodes each day, which was non bilious and non projectile. There was no history of pain in abdomen or jaundice, no history of blood in stools, no history of joint pain or rash, and no history of decreased urine output. For the above complaints, child was admitted to an outside hospital where antibiotic zone and vanco was given. The child was admitted for 4 days where a diagnosis of inflammatory bowel disease was made. At 3 years of age, the child, there is also past history of previous admission. At 3 years of age, the child had fever which lasted for 1 month and there was pain in abdomen with vomiting and loose stools, where the child was diagnosed with multiple ileal perforation, for which exploratory laparotomy with ileal resection and anastomosis was done, and with pericardial effusion with CCF and anemia. At that time, the child had received antibiotics, peptaz and amikacin, and also had received AKT as well, and was kept on parenteral nutrition for 14 days. Histopathology of the tissue after resection was suggestive of granulomatous inflammation with ulceration and perforation. Whereas tissue culture was positive for E. coli and Candida. P. anca was done, which was negative, and fecal calprotectin was 2400. Child was up well for 2 years with weight gain present, and there was history of measles 1 year back. ANC history was uneventful. Birth and developmentally, the child was normal. Immunized, the child is immunized till date with no any significant family history.
Okay, so now with this opening history, what do you think? 12-day history of fever, loose stools and vomitings in 7 days. What are your thoughts?
acute gastroenteritis, uh, or uh, food food poisoning can be a possibility. So,
We think it is gastro and food poisoning. So you must have seen so many cases of gastro. How do they start? How long does it go on?
it starts off with fever, with short history, not so much long 1 week history usually never. Uh, but it's not too long to grade it as IBD. Yeah, chronic costly.
A bacterial cause, most likely in small intestine.
Bacterial infection of the small intestine. Okay. What kind of infection?
So in the history later, it was mentioned that the patient had intestinal perforations. So could be typhoid.
Okay. Now, typhoid, for example, in this child, if you consider typhoid, you may have seen several cases of typhoid. How do they normally present? Pardon me?
Step ladder pattern of fever.
Yeah. So usually the fever may be little low, goes on increasing gradually over a period of time, and then loose motions and vomiting. Now here the loose motion started first or the fever started first? And after 5 to 7 days of fever, the loose motion started. So we'll suppose that can occur in typhoid. Then do you think it is still likely to be enteric fever? Why not? Was the fever still rising on day 7, day 6? Or it really rose up for first 2, 3 days and then it has been more or less constant, more or less. So first 1 or 2 days it took the rise and more or less constant and loose motions and vomiting. How how do you say that in typhoid? What usually happens in typhoid? Okay, rising tetano fever. So maybe the fever did rise to what it has in the first 2, 3 days. Sometimes it may take 4, 5 days to rise, sometimes 2, 3 days. Then, because typhoid is a gastrointestinal infection, it can present as vomiting and loose motions. But for so many days and so many vomits, occasionally it can present for a little longer period of diarrhea. Diarrhea is there as a part and parcel. Abdominal pain often dominates and so many loose motions and vomiting is not common in typhoid. He's having everyday vomiting for 7 days. So it's unlikely to be typhoid. Can it be just simple gastro? Why not? You have seen several gastros. Do they present like that?
Sir, it can also be viral gastroenteritis.
Yeah, but a viral gastroenteritis, when will the vomiting and loose motion start? Right on the first day or second day, not like that. S-
Why did it can be for so long, like for 7 days?
Yeah, so it's not likely to be a viral infection going on for 6, 7 days, even if it was viral GI. If it is viral GI, it should have presented much earlier with vomiting, loose motions. Any viral infection, maybe of intestine, going on for 14 days is less likely, and GI infection, though, definitely less. So when patient, what really alerts us is he had fever for 7 days, and if you want to call GI infection as a GI infection as a localization, then vomiting coming thereafter and persistent. Occasional vomiting once or twice is so. Every day he vomited several times and loose motions is really an uncommon picture for any GI infection. Can it be parenteral diarrhea? The infection is somewhere and he's getting diarrhea because of that. Even then, parenteral diarrhea, the loose motions may not be so much and not associated several vomits per day. He had several vomits per day for several days. So, parenteral diarrhea or systemic infection with GI manifestation, no. Primary GI manifestations unlikely. Tuberculosis will not present with high fever. So, presence of high fever and GI itself alerts you that this is not something which we normally see. None of the gastros we see like that. Even the enteric fever is not like that, parenteral. So you are dealing with something else. Now, if you are dealing with something else, a prolonged loose motions may be coupled with vomiting, no vomiting, with fever could alert you for an inflammatory bowel disease. More so if there are one or two more signs and symptoms. And what were they? What was I expecting which is not there, or maybe it's not mentioned? What about abdominal pain? Usually an abdominal pain is often a very prominent manifestations in the inflammatory diseases. Here I'm surprised that there was no abdominal pain. And sometimes if there is blood in the stool, it may help. If it was a blood in the stool, would you call it dysentery, bacillus dysentery, Shigella? Unlikely. Shigella presents with loose motions, with blood in stool much earlier, doesn't go on for 14, 15 days. So none of those infective causes. So we do think of an inflammatory disease. And though there may be no abdominal pain, blood would have helped. Absence of blood doesn't help. Where do you think the pathology is like? If it is an inflammatory, is it there can be inflammatory disease involving large intestine, small intestine, and ileocecal junction? Where do you think that? Why? Okay, large intestinal don't yeah, you have made volume. Anything else? How is the large intestine loose motions as against small intestine loose motion?
Just full watery.
Watery diarrhea, often usually with crampy abdominal pain. I again feel why the and large bowel motions are often sticky and with tenesmus, as we call it, small, sticky, many motions with lot of mucus more than anything else. So maybe small inflammatory disease. We are not able to say whether ileocular junction is there or no. So most probably small the intestinal inflammatory disease, mostly not tuberculosis. So we have to think of inflammatory disease. The points against I would have liked to have, which abdominal pain has to be there in most of the inflammatory disease. Absence of abdominal pain is not against it, but it should have been there. So mostly we are dealing with inflammation without the past history. When the past history comes, then you are a little more certain. Please remember, this is not a very common diagnosis in practice where somebody comes with diarrhea and vomiting. But what is unusual is the duration of fever, duration of vomiting, loose motion, and vomiting also. Usually, vomiting and diarrhea, vomiting stops after the loose motion start, and sometimes loose motions can continue. But persistence of vomiting and diarrhea and fever are not the common features in most of the GI infections. So I think small intestinal, probably inflammatory disease, malignancy unlikely for 5-year-old presenting like that. That's what we think even without the past history. Usually, bacterial diarrheas of small intestine do not go on for such a long time. Most of the time, even if it starts with high fever, persistence of high fever for 14 days is uncommon except in enteric fever, which is also an intestinal infection. But persistence of vomiting, 12 to 14 loose motions is not common. Therefore, an intestinal bacterial infections not likely. Large intestinal infections are more like colitis, which is again in most of these infections, US don't go out for 14 days. The fever may subside and only the GI manifestations will continue. Abdominal pain, loose motions, and some vomiting are three common things that should have been there.
I think let's not jump to what it could be. First 5 days there was only fever, no? Start analyzing that. Okay, if you were there on first 5 days, you had no reason to talk about intestinal infection, whatever. Then how would you have gone for? Now, when you see 5 days fever, uh, do we have any details of fever?
The fever was intermittent in nature with 2 to 3 fever spikes a day, and there was no any history of chills, rash, or rigors. The child was active in interfebrile period.
See, all these details have to be asked for. And therefore, if I believe that the fever pattern was every 6, 8 hours, okay, in between the child was all right. And at the end of 5 days, I know that it has not had any localization. Bacterial infection is out. Viral infection is out. They are acute infection where an intestinal symptoms come very early in the course of disease. So in the first 5 days, the fever looked to be non-infective fever. That's number one. Or what else could it do? So first, we have said this again and again, that history starts saying that how well was the child prior to this onset. We have not heard that. Do you know how well was the child? No, how was the child well till then? Was he growing well? Was he active? Was he playful? Was he happy? Was he eating well? So many things you need to know. So it was a normal child? I would not believe that. Then what is what? See, this is what you want to learn. Okay. We don't want to go through 10 possibilities. And therefore, if we started with this child not growing well, there is something behind 5 years ago. And that something behind must be 5 years is not doing well. So it must be a secondary malnutrition, not nutritional. Okay. What happens in nutritional is generally first year. Anything who is not growing thereafter has to have a secondary cause. Now, if we keep that in mind, and then the fever had not localized, so could it be some chronic pathology? Okay. Because of malnutrition, he's not demonstrating any quick localization because it's not an acute infection. So the whole story starts with that this is an abnormal host, not doing well, and now has running fever for 5 days. Okay. Then symptoms came of diarrhea and vomiting. When there is a diarrhea and vomiting persisting, that means the story anatomy is right from stomach down to intestines. So it is gastroenteral anatomy. So again, inflammatory bowel looks unlikely. Why is it there be vomiting so much? Yes, duodenum is often involved in inflammatory bowel disease. Okay. But the symptoms are generally intestinal, not persistent vomiting like that. That means right from stomach down to intestine, maybe large intestine, everything is involved. So we have a large area of gastrointestinal tract involved. Again, inflammatory bowel disease, generally Crohn's is colon, most colon. Okay. And therefore, the it could be duodenum as well. But this is not a story of inflammatory bowel disease. So what is then it could be? It could be some infection, some likely infection which is not localized. In other words, it's a chronic infection or infection which is growing slowly. Could it be tubercle? No. Could it be fungal? Maybe. And if this child is malnourished, then this child is immunocompromised. So that's one way of looking at it. Now, how do you diagnose the immune compromised pathology? Just one word, unusual. Anything happening unusually, the host is not normal. This is not happening routinely. There is something wrong in the sequence of events, which tells me that this child is likely to be immunocompromised. Now, if you get an immunocompromised child, I mean, we are just thinking aloud. It may be totally wrong, but I'm giving you a concept of thinking. So we have come to a conclusion that this must be a chronic problem, recurrent problem, unusual, must be immunocompromised. Why is he immunocompromised? Could it be only a severe malnutrition? Unlikely at this is primary. Therefore, there has to be a secondary cause. Then could it be really an immune deficient since birth? Okay, it could occur any time thereafter. Further, any immune related problem has any of the three uh, facts. Immune deficiency is one, immunoreactive is another, and immune dysregulation is the third. What does it mean? Immune deficiency fellow keeps on getting infection. The immune reactive fellow is triggered by some infection, then develops immunological disorders in multiple organs. Or it could be autoimmune. That means no trigger, but by himself is throwing that, which is called a reactive inflammatory disease. And the third one is immune dysregulation, which means malignancy. All three can overlap each other. So the question is this an overlap syndrome of an immune deficient patient? So what immune deficient patient can have overlap? Immune deficiency, probably. What is overlap? Malignancy, most unlikely. So now comes the inflammation. Okay. Now look at the diarrhea properly. Is diarrhea with a mucus, with a blood? No. Then where is the inflammation in the intestine? Is a malabsorption. But why should the vomiting be there? If this child is very much low in health, then the intestines are not working well. There may be metabolic problems like hypokalemia, multiple reasons why this child can have a malabsorption as well. And therefore, my conclusion is one is likely to be an abnormal host. Second, the most abnormal host is immune deficient. Could it be a child born with some anatomical malformation of the intestine? For example, there are children born with a small length of intestine. They have malabsorption because intestines is not big enough to absorb. So such things cannot be even considered and they are rare. So now, what are the other inflammatory disorders which may look like inflammatory bowel? For example, eosinophilic gastroenteritis. All that can be diagnosed only by histopathology. The clinician cannot talk about it. So I strongly feel that this host is abnormal. He's getting diarrhea, vomiting, which could be simply malabsorption. Okay, so no inflammation, but some fever, so some trigger. And if the fever is persisting for almost 12 days, then it's likely to be a chronic infection. If it's immunodeficient in my thinking, then it's a fungal infection. Now, everything may be wrong. Okay, we are just analyzing it in a manner that it may be difficult for you to reject my hypothesis. My hypothesis may be wrong, but it's difficult to reject because we have systematically analyzed how we came to abnormal host, immune problem, chronic infection, and multifactorial, maybe malabsorption.
Sir, can it be celiac disease? Uh,
So basically, see, first,
Basically, autoinflammatory disease. So overlap, but celiac alone will not keep on coming with fever, vomiting, etc.
basically, first we should learn to develop an approach. So don't pick up one diagnosis and see is it fitting in the other diagnosis and see is it fitting in. So as sir explained, started with fever for 5 days. What would be your first thought? Fever commonly is infection. Then you decide, Arey, but this infection is not localizing. Why? So then you go on to whether it's a unusual infection, oblique no infection. Correct.
But celiac is an inflammatory disorder. And remember, celiac inflammation doesn't mean blood mucus fever. Okay, so it's a different kind of inflammation where there is no fever as a predominant feature. Normally we say inflammation means fever, but inflammation may not have all characteristic symptoms of inflammation. Okay, there may be pain but no fever. There may be a fever but no pain, and so on and so forth. So to me, it's some immunological problem, but immune deficiency at that. Again, look at what happened at 3 years ago. Again, a similar intestinal problem. Okay. When they said ileal perforation. No, perforation occurring at that age, okay, in adults, the typical inflammatory bowel disease, Crohn's doesn't do that. But in adults, you will have ileal perforation, but not in children. And therefore, again, it tells me that this must have been a chronic process, which to my mind is chronic infection, therefore fungus, therefore immune deficiency. I think all this would be a consideration. This is certainly unusual. What comes out, we will learn backwards and say, could we have picked up what the final diagnosis is? But just now, this is the concept. Right?
So the earlier illness, at the end of all that, it was diagnosed as SAM. So again, what thought should come to your mind? 3-year-old had that 1 month febrile illness, GI illness, and was diagnosed as SAM. What thought should come to your mind? So whenever you see any SAM, one is you have to look at the history. Normally, where do you get SAM? Because of nutritional inadequacy right from the beginning, right? So you have to see whether the history is fitting in and is it a primary nutritional deficiency. You must check that. Is history of nutrition at 6 months, 1 year, whatever. And then second would be otherwise it is disease related. So that means if nutrition is not so bad, then there is some disease which is going on, which is making him malnourished at 3 years of age, right? Then similarly, we are talking of immune deficiency, so we must look at infections before that 3 years of age, whether this child was unwell in any way for those first 3 years or whether it was absolutely all right, right? On a different note, there's this pericardial effusion with CCF with anemia. So now what are your thoughts on pericardial effusion? When have you seen pericardial effusion in children? Forget this case and then we'll take it further.
CCF, it is seen. CCF or if anemia with failure.
Wouldn't really give you pericardial effusion. So again, you have to classify your thoughts. So one is,
If this causes TB or any viral this
so one is infectious where it is local, so primary pericardial effusion. And one is as a part of a generalized transudate. So everywhere fluid is filling in, like a pleural effusion, ascites, everywhere, even there it is filling in. So all these thoughts should come in that he was in cardiac failure. If he had transudates everywhere and a little bit of pericardial effusion on 2D echo, then that's a different ball game. But a pericardial effusion that comes in as a presenting pericardial effusion, then like you said, whether there's any local infection, etc. So this is the way you have to think of all the possibilities, right? We need a lot of details for all that.
Remember the first para. This happens commonly with all of us. Okay. Considered as inflammatory bowel disease, but treatment, two antibiotics. See how the person thinks of one thing but gives two antibiotics. Isn't it funny? He should have not considered IBD. I could have allowed it. So not why two antibiotics and one vancomycin. Okay. So these are real problems in practice. Okay. And why? Because we don't think before. The same man is making statement in the same paragraph against each other. Inflammatory bowel disease with two antibiotics.
Antibiotic may have been given because of perforation. Because once the perforation occurs, then peritonitis.
Stage diagnosis was admitted for 4 days. Thereafter,
This is of the current complaints, sir. The first para is for the current complaints and the perforation and all happened at 3 years of age. Presently is 5 years of age. He is 5 years of age admitted with that fever. Okay. Fine. So now that's all that we can make out from this history. There's nothing more. So now you tell us the examination findings and anthropometry and all that.
On on general physical examination, the child was afebrile with heart rate of 120, RR of 32, peripheral and central pulses well felt, and there was pallor present with grade 1 clubbing and hyperpigmented spots were present on thigh. Oral ulcers and post-op scar on abdomen was present. Anthrop
Hypopigmented spots on thigh with oral ulcers likely to be immunodeficient.
Any interpretation of these findings, sir, is asking.
clubbing, hyperpigmented spot, oral ulcers could be multisystemic involvement also. In autoimmune or primary immunodeficiency.
Febrile child, no? Why 120 pulse rate? So why is the pulse rate so high? Fast. So febrile. And respiratory rate almost 1 to 4. So both are equally high. What must be the cause?
There is also grade 1 clubbing, pallor. So the heart is trying to compensate for the decreased blood oxygen out, oxygen flow.
So see, first of all, don't bring in the grade 1 clubbing here. Leave that aside for the time being. Now, when you have a afebrile child with a heart rate of 120, you said pallor. This is a 5-year-old child. So pallor has to be considerably significant for you to get that kind of a tachycardia, right? Here you've written pallor 1 plus. So it's not that significant. The second thing is you wouldn't get tachypnea proportionate to that. When you have tachycardia and tachypnea proportionate to each other, we call it a systemic inflammatory response. Okay. Now, in the light of our discussion, we have to wonder whether this child is unable to mount fever. That is one possibility. So the child is totally undernourished or immunocompromised and cannot mount fever. Or then this is a inflammation of some kind which is showing all this, right? Then whether he is still in cardiac failure and that is causing both tachypnea, tachycardia, but for that we will need more signs.
So the child was feverish, like in the presentation. So maybe they just temporarily suspended the fever by giving any analgesic. But the RR and
So that's what, no? If the RR and HR is because of the fever, when fever subsides with antipyretic, HR and RR also come down, right? If HR and RR are maintained in spite of no fever, there has to be some other reason for that HRR, right? Hypopigmented spots is a very non-specific thing. You need to give more detail and you can't jump to immunodeficiency and all that. Even an old skin lesion heals with hyperpigmentation. So this thing actually.
On anthropometry, the child was had a weight of 14.65 kg, which falls under -2 to -1 standard deviation. Height of 108 centimeter, which fell under -1 to 0 standard deviation. With BMI of 12, -3 to -2 standard deviation. So anthropometry wise, the child was thin. On systemic examination, respiratory system was normal. CVS was normal with grade 1 murmur over the aortic area, and CNS was normal. And per abdomen wise, it was soft. Generalized distension was there with guarding, tender hepatomegaly, and mild splenomegaly was present.
So first, what do you make out of the growth? What do you think? 5 year old, no? 5 years.
According to BMI, it's thin. Otherwise, height is okay only for the child. Uh,
So when the height is okay with this story which we had and which we were discussing just now, whether he's a immunocompromised child, whether he's a malnourished child, at 3 years he was diagnosed as Sam. In light of all that, what do you think of the height now?
that's the height.
So can you catch up on height? If you have lost height, if you got stunted because of Sam, can you pick up that height? Correct. But then that time, if he was diagnosed as Sam, technically definition of Sam is wasted and stunted. So if he was stunted that time, then how can his height be normal today? Right? So that means he was not stunted that time. These are, I'm just saying, think of all these things when you take a case or when you take a history. Exactly. Or it is not 108 today. One of the two things have to be wrong. Right? So keep thinking. Patient has come. No. Yeah. So
Sick and he's prepared for a colonoscopy tomorrow. So and child is sick also, so cannot be could not be shifted.
what do you make out of these findings? So murmur over the aortic area would mean what? Aortic regurgitation, aortic stenosis, all those things. First, you need to know a lot of details about the murmur before you jump to all that. Right? Okay. Yeah. So if this is a, we're talking of pallor in this child. So can you have a functional murmur? Of course, the degree of pallor has to be much more. And then if that functional murmur, is it systolic or diastolic?
Rejection is called.
Systolic murmur, right? So we need lot of details on that murmur also to make out anything out of it. And uh, yeah, BP did not say, no? What is the BP? You don't know. Then soft generalized distension with guarding, tender hepatomegaly, and mild splenomegaly. So any thoughts on all these findings? What would these mean?
The pathology, the inflammation is progressing. Maybe it is involving the liver and also spleen now. It's progress.
Where is the mic?
So to call it peritonitis, you would need rigidity as well, along with the guarding. And so basically, it means that the intestines are inflamed all over because it is generalized. Now, again, that tender hepatomegaly, we need details and we need other details to check whether there is cardiac failure because even cardiac failure can give you a tender hepatomegaly, right? So there are a lot of incomplete things here to discuss.
I think that's why we must have patience here to check. Okay. So many things we don't know. Then how will we know whether our thinking is right or not? First, can it be soft and guarding? Two things are different. How can two things be together? Guarding is really a muscle spasm. Okay. It's not soft. So soft and guarding don't go together. Okay. So many things we would have confirmed by looking at the patient where we are. Again, hepatomegaly means what's the liver stand like? Okay. What is the liver stand like? Is it large liver or is just a hypochondrium is tender? So many things we don't know. So I think that when there is no fun in clinical discussion at all, then why discuss? Do all investigations and diagnose. Okay. There is a reason to teach like this. No? There is no reason. So modern medicine needs no thinking, and AI will take over totally. So where is the problem, isn't it? If the findings are also not, it, it's difficult to discuss such things. And then we have had times when finally it turned out to be typhoid, but there was no liver, no spleen at all. So people go out saying, "Oh, I've seen typhoid without liver and spleen." So we get the wrong impressions of that. Eh, Let's see whether some investigations have shown something.
Just wondering that 3 years of age, multiple perforations means what? That means the intestines were so much thinned out and perforated, not at one place, but no. And if we consider the same disease now, then but any of those, but pain is absent, but maybe sometimes.
Uh, Further investigations was done. CBC was hemoglobin was of 9.8, hematocrit 29.9, WBC count of 24,500 and platelet of 7,87,000. CRP was 99, ESR was 64, OTPT and bilirubin was normal, protein was 5.7, total protein and albumin was 2.6. RFTs was normal. Thyroid function test T3 was there was low T3 and stool RM was shown 40 to 60 pus cells with occult blood positive and 6 to 8 RBCs. CECT abdomen was done outside, which was suggestive of mild hepatomegaly with fatty attenuation of liver, diffuse long segment circumferential wall thickening of terminal ileum and colon, showing thickened hyper-enhancing mucosa and engorged vasa recta. USG was suggestive of mild hepatomegaly with mild enlarged non-necrotic mesenteric lymph nodes, diffusely thickened colon with few thickened small bowel lobes. 2D echo was suggestive of thin rim of pericardial effusion with preserved ejection fraction. Uh, mm, uh, Inflammatory bowel disease based on the finding, most likely uh, most likely Crohn. Mm. No,
Fine. So I think there are many things which are incomplete, so we don't know exactly. We can't correlate the clinical picture. But again, just to keep learning. So we were talking of how much pallor and whether that tachycardia, tachypnea could be explained by pallor, whether this child was in cardiac failure, whether that was explaining the tender hepatomegaly. Now your hemoglobin is 9, so that cannot cause all that, right? So that, yeah. So one is you must make a note that hemoglobin is 9, so all that is not possible. So you have to recheck all the findings, whether they were really there, and then if there's any alternate explanation, right? Now, sir is saying platelet 7 lakhs. So, what are your thoughts on platelet 7 lakhs in general? When you have such, yeah, due to what? What is the interpretation?
I think platelet usually increases with pneumonia, all these infections usually platelet rises, thrombocytosis.
So, it's a sign of inflammation. Okay. It is commonly seen in inflammatory disorders where you get neutrophilic leukocytosis and thrombocytosis. Okay, but you have to, again, basically, you have to correlate with your clinical picture. Any other simpler reason for thrombocytosis, which is not here, but I'm just saying, much more common, and not to this degree, not 7 lakhs. Hmm? Iron deficiency anemia tends to cause thrombocytosis, right? Okay. And of course, in a given situation, even a abscess, like a very necrotizing infection, abscess in the liver, etc., may cause very high, quite high platelet counts. Of course, you have to correlate with the whole clinical picture. So, at best, we can say that with this thickening of terminal ileum, there is some chronic inflammation there. So usually your DD is between tuberculosis and inflammatory bowel or regional ileitis or Crohn's, what is called as. And this child is quite healthy and otherwise the story doesn't look like tuberculosis. So at best we can call it Crohn's, right?
That means another place of inflammation. Like we have the pleura, pericardium. Only thing is very thin. So whether we take it, whether it should not be a reason, it's not sincere. So it has to be explained on the basis of inflammation. But we need to keep many things in mind. Sir, these days, more and more inflammatory disorders are being diagnosed. Maybe we were not seeing, but now we see more of that as compared to what we used to see 10, 15 years back. And this is not something which you would have missed 10, 15 years. I mean, somebody with 15 days diarrhea, you are not going to consider GI infection, GRDS. And somehow I don't.
What is funny is at 3 years of suffering like this, in between 2 years normal. So what was the treatment given at that time? IBD will not behave like that to me. IBD may get well, or then IBD may keep on recurring. In between 2 years, it went well. Again, that liver spleen. But we are not sure about many things. And I think that's why we must have a patient to examine. Okay. Sometimes, I'm sure earlier, uh, it's 25 years we are coming in. Earlier, we used to have even a history check. Okay. Patient would be on the last thing, and one of us would check the history and find that the history is also different. It's not, yeah, because, see, yeah, I mean, I'm rude, but we are forcing you to come here. Okay. Now, if we are forcing you to come here, why should we be forcing you? Therefore, you pick up something, not even see something. Okay, come here and present. Okay. Just now, the professor of neonatology was asking me how many people come. I was ashamed to say how many people come. Okay. But even your attempts are possibly just to satisfy mind. And forget, 2 weeks ago we were told we must have every Thursday. We had opted out alternate. Okay. Isn't it? Thereafter, if this is the position, I think time has come to my mind that we must stop this. Because you are forcing. Okay. What are we doing? Okay. We don't know the finding. We don't know details. And we are discussing. Okay. That is not the right thing at all. Okay. And what are we discussing? So, like, I don't know this, I don't know that. What do you think about it? Okay. Means I'm quite dejected, depressed, and at my age, I will stop coming. Because, we see, what do we make out of this? No, I can understand. If you don't tell me blood pressure also, okay, no, that is not acceptable. That means I understand you are very busy, but one of you has to come here because we come here. And one of you has to say something. Okay. And we dwell on something that is unknown. It's not fair to us to go on discussing something which may not be there. Isn't it? Hmm.
As far as possible, they will bring a patient. Maybe this time it was not there. Still, sir, I would say it does stimulate.
No, no. The effort that we are taking are not what stimulating. Okay. If they're stimulated, they would come here. These two undergraduates come here. Okay. So possibly they don't need it. I'm not forcing you. You will do well without teaching. Where is the problem? I'm happy about it. I really sincerely feel that. Just now, your professor of neonat, तर किती लोक येतात म्हटलं अगं दोन तीन जे येतात He said, अरे इतके रेसिडेंट्स आहेत दोन तीनच येत आहेत and she is the one who has attended our Sion Hospital clinic and she also used to come to Bombay Central when we started. She remembers that. He was asking me why people don't come. Is it? Yeah. Anyway, what I feel, it's my view. It's not necessary that I have to come. The clinic can go on as well. You may come. I also may come. Okay. It's not fair. No, I think we have said this umpteen number of times. But for whatever reason, you may be overworked, then you cannot spend time like this learning. You will learn enough. Okay. Failure at MD is very difficult. So don't worry about it. Okay. And therefore, if that is the aim, then aim is satisfied. I'm sorry to say all this, but this is very depressing.
Second case is there.
Or if there is occult blood and there is also features of like uh, weight loss, like decreased weight and all. Why can't it be maybe colon adenocarcinoma or something like that? Colon adenocarcinoma or
See, first of all, those carcinomas are very uncommon in children at this age. Okay. So, no, yeah, that is also there. But the point is that, like I told you half an hour ago, we shouldn't jump to, try to fit in one or two diagnoses. So you have to make the process in your mind. That am I looking at a infection? Am I looking at a non-infective disorder? Then from there, once you come to a non-infective disorder, then you start thinking of inflammatory disorders, malignancy. So this should always be your process in any system, any symptoms that are presented, right? So here, because we have not come to malignancy at all, so then we will not discuss which adenocarcinoma or whatever. You get my point?
Suggestion that tell the colonoscopist that look for something even beyond inflammatory bowel classically. There is something like eosinophilic gastroenteritis. There are different inflammatory disorders of the intestine, and I'm sure they will take a biopsy as well, so that we will know where we stand. Only because this is unusual presentation, and therefore we must think about something unusual, and just let them know that.
Last time they have reported granulomatous inflammation, which, I mean, of course, that also is there, but this time again, we should see what exactly it is.
Good evening, all. I'm going to present a short case. Uh, the child, 14-month-old girl child, third by birth order, born out of non-consanguineous marriage, hailing from UP, residing at Vasai, Harijan by community, Hindu by religion, informant being mother, presented with complaints of not gaining weight since 2 months and recurrent episodes of fever since 2 months. Child was apparently normal 2 months back. A child developed recurrent fever. Fever was on and off, low grade, documented, and relieved on medications. Child was active in interfebrile period. Parents also noticed that child is not gaining weight according to the age. For the above complaints, child was admitted in outside hospital. Further evaluation there revealed decreased blood counts and blood transfusion was done following this. There is no history of breathlessness, no history of vomiting, loose stools, no history of Cox contact, no history of passage of worms and stools, no history of pica, no history of leather. In past history, there is no history of previous admissions in past. ANC history is registered, has taken iron and folic acid, 2 doses of PT taken. Mother had a history of hypertension in pregnancy at 6 months and she was on tablet. Birth history, moderate preterm. It was LS years with 1.1 kg. And there was a history of 48 days of NICU stay in view of low birth weight, sepsis, and meningitis. Immunization is still there. Development history, gross motor. The child is actually 14 months old, but child only sits with support. And fine motor, the immature pincer grasp is now developing. Language, which is cool, it does not unisyllables, कुछ syllables नहीं है. Socially, he has stranger anxiety. So impression, global developmental delay is present. Dietary history, the child was exclusively breastfed till 6 months of age and even now consumes only milk. No complementary feeds were started up till now at an age of 14 months. Family history, it's a non-consanguineous marriage and the uh, first child was a male child who passed away on day of life 2 and second child passed away on day of life 1. First child was born at 7.5 months and second child was term but eventually passed on day of life 1. Details are not available. Summary, 14-month-old girl.
Okay. So, uh, again, now we have lot of specific things that are missing. Doesn't matter. Whatever is there, we'll learn an approach. Okay. So now this mother has come to you. We'll start from history taking. This mother has come to you saying that 2 months there's fever and not gaining weight, right? So your statement that child was apparently normal. So I'm just saying, I know you are a young fresher, so you need to learn. Long way to go, no problem. So what will we ask to means what is common sense here? We need not be doctors. When they come and tell us this history, what common sense tells you what should we ask? So apparently, all right, 2 months back means what?
Completely normal, but
Right. So completely normal. So you would like to ask that, right? Now, how will you ask them? Just related to these complaints, tell me how will you ask them? Okay, so one is eat well, play well. What else?
gaining weight normally is it last.
How does a parent know that the child is gaining weight? Increased appetite doesn't mean gaining weight, no?
He just compares with the other age group child and just comment upon that.
Okay, so one is compare with other children, then The point I'm trying to drive at is that in this child, if I would have taken the history, I would have asked her, "Okay, what makes you feel that he is not putting on weight for last 2 months? Did you check the weight 2 months back and did you check the weight now and you feel it is same? And more so when you have a history of birth weight of 1 kg. Okay. So I'm now diverting a little. This is a 14-month-old child. A normal 14-month-old. How much weight does this normal 14-month-old gain from 12 month to 14 month? That's the history here, no? At last 2 months there has been no weight gain. So how much does a normal, forget this, normal 12-month-old gain till 14 months? Any idea? Okay, forget. 12 month is 1 year. How much does a normal child gain in the second year of life? 1 year to 2 years.
1 year is usually 9 kgs, considering 3 kgs worth it. Then it would be around 12, somewhere.
Fine, 11 or 12. So 2 kg in that whole second year. Now divide it into 12 months. 2 kg in 12 months. Even though it may not be exactly averaged out. So how much does 1 month come to? 200 grams. Okay. Now you are supposed to make out visually that you have not gained 200 grams in 2 months. Not possible. No? So what I'm trying to say is this is the way you have to take history to understand the problem. How did the mother come to this conclusion? Okay. Now, yeah.
I had a look at developmental milestones. They were delayed. So how can we say that?
So that's what, na? So that all right is in what respect? So in short, we want to know what are we trying? All this jhanjat, why are we doing? We want to know the onset of the illness. We're trying to define that, right?
Probably what you mean whenever you say apparently all right is referred to chief complaint. If his chief complaint is he has cough, that means apparently all right 3 months back means the cough was not there earlier. That's what it does not probably mean that he was really everything was all right for 2 months. We'll forget that. You can say that apparently all right next. The cough started for 2 months. Before that, there was no cough. Without the general, etc., we'll see. So cough is for 2 months. And fever also for 2 months, on and off. On how much and off? What I mean is 5, 6 days of fever and 1 or 2 days, or 1 or 2 days of fever and nothing for 15, 20 days. That's also okay.
To sum up all this last 10 minutes, what I am driving at is that parents also notice child is not gaining weight according to age. Is not only for this 2 months. It is since time immemorial. And that changes the whole thought process. So you delete that from your present illness as a contributing to your analysis, right? Why is not gaining weight since birth? We'll talk of separately. We have reasons for that also. Okay. Now, sir, it's beyond. They are good to tell us what a normal baby gains in the second. Okay. So I was asking how would a 1 kg baby gain weight? Any idea? Born at 1 kg, no? So by our thumb rule, double at 5 months. So 2 kg at 5 months, right? Right? Pediatricians. No, it's not possible. All that is nonsense. So that double at 5 months and triple at 1 year is a very crude rule, but the original should be normal. Then that crude rule applies. If your original is not normal, that crude rule is to be thrown away. So you can't have a 1 kg child, 2 kg at 5 months and 3 at 1 year. So what will decide how this 1 kg baby will grow? What will decide? Any thoughts?
Why the child was 1 kg in the first place?
What are the two big reasons for being 1 kg at birth? Two big reasons. There can be 100 reasons.
One, maternal malnutrition, and uh, two, maybe
It was preterm.
Preterm and what is the other big one? IUGR. So now between preterm and IUGR, you have to decide. So who will grow better? Suppose this 1 kg at birth baby was preterm and it was IUGR. Who will grow better?
Preterm.
Very good. So preterm will grow better. Preterm AGA. Meaning prematurity is the main reason for the low birth rate. Then they'll grow well. They'll catch up. Okay. And the IUGR will not catch up to the mark, may catch up slow. Then next question is, what is the next question in an IUGR baby in your mind? When did the IUGR start? So symmetric or asymmetric? Okay, first trimester or later? And who will grow better? Later. So asymmetric will grow better, right? Then you've written in fever that it was low grade but documented, right? So good. You said documented, undocumented. But if it's documented, then you have to tell us how much it is, right? And you have to give more detail that it was 99, it was 2 months. So you have to give some idea, no? Okay, how many days in these 2 months? So every 3, 4 days or what? Some idea you have to give us about the fever, right? So far we don't have any details of all this. Now, okay. Again, we are just learning. So what all this, why did you ask these questions? And then we'll discuss how to fine tune them. So don't worry. Just tell us why you asked these questions.
Find the fever focus के लिए vomiting, loose stools, and cough, cold, and breathlessness was asked, and Cox contact because he was not gaining weight again. So TB could be ruled out. Uh, Passage of worms and stools, again anemia. When the infestations, helminthic infection infestations can should be ruled out, and pica anemia ruled out. Lethargy can also come in part of anemia or any infectious chronic infectious causes.
Now, assuming that there is definitely fever, and since you said it's low grade, we are believing it, and it's for 2 months, right? Now, what thoughts come to your mind? 2 months low grade fever. So, what thoughts come to your mind? So, again, start from very broad. So, start from is it infection? If infection, what type of infection? Then, what else? Think of all that. What do you think?
In India, TB can always be a cause of blood.
Yeah, in India, TB always, but so don't take it as a direct etiological diagnosis. So think of infection. In infection, can it be acute infection?
It's 2 months these cases.
Correct. So now what other parameter will disturb your analysis and which data you want? Treatment. In these 2 months, first starting some fever, went, took some antibiotic, got half better, then again some. So you need all those details, no? Okay, whether it's a infection which is being treated again and again. It can't last for 2 months, but I'm just explaining that, right? Then it can be a chronic infection. Can it be anything else? Where else can you get low grade fever? So again, as a concept, you can get low grade fever in any massive cell breakdown, wherever there is a cell breakdown for whatever reason. right? Okay. Now, so when you say moderate preterm means what kind of gestation?
33 to 34 plus 60. Less than 32 weeks is early preterm. 32 to 34 is moderate preterm. 34 to
So that means this was 32 to 34-week gestation, right? Comment on that. So 32 to 34-week gestation and 1 kg at birth. A comment on that.
1 kilogram birth weight is less even considering 30 to 34 weeks gestation. Means that the other IUGR is there.
Excellent. So this is prematurity with SG or IUGR, right? So that is again an inference. Now talk about the development. So whatever. So gross motor sits with support. Okay. Now it's not normal, right? It's delayed. For 14 months of age, it is delayed. Hmm? Yeah. So now what else should you know in this?
preterm here वो contribute
So you can consider, so you give an allowance for 4 weeks or 6 weeks, whatever you want to. Though that allowance is more in the beginning. Now, after 1 year of age, that allowance may or may not be important. Right? Second thing. So when did this baby start sitting with support? Why is that important? Hmm? Prashant, why is that important? When did this baby start sitting with support?
there is the development progressing as diabetes.
Very good. So you want to know the speed of development. Okay. Is the speed same? Is it getting better? Is it getting worse? Right? Right. Then fine motor is immature pincer grasp. So that sitting with support corresponds to what age?
With support 6 months and without
6 months. Fine motor immature pincer grasp corresponds to 8 months. Language, again, we've made this point again. Fine, immature pincer grasp on history is very difficult. It has to be an examination. Okay. Then language cooing in
sounds only, no meaningful mark. It's a unisyllable dictionary.
what does that age come to? Okay. So if it is right, then it age goes backward, but we'll have to double check on that. And then social, there is stranger anxiety is present.
Even
So again, now just to check whether you are thinking as you are taking the history. Out of the all four domains, which is the domain which is most delayed?
language according to the
So now in this child, does it ring a bell? You have the history, you have prematurity, you have IUGR, you have sepsis, meningitis, and now you have language delay. Most. Can you connect something? Something you should look for?
hearing.
Superb. Very good. It can cause a hearing deficit. So you have to keep thinking like this, that why is a language disproportionately delayed? Is there something wrong with the hearing? It's disproportionate, right? Very good. So that's the way you have to keep thinking. Okay. Come now. We have a baby here, so we'll try and examine the baby. हाँ जी लेके आइए.
Examination general condition appears fair. Mm, from head to toe.
Always make it a habit, like you said, fair. So in that fair, what have you considered in your mind?
Lethargic.
One, you have considered how sick the child is,
Non-sickness.
not sick. Second, what did you consider when you said fair general condition?
Not severely thin and malnourished.
Very good. So growth. So now make it a habit that every child, first two things you will look at is sick or not sick, and growth. What is the growth? Always you look at these two, right? Okay.
From head to toe, if you see, the hair is kind of sparse hair present. Frontal bossing is kind of present. Mm. The pallor is present. Um, wrist widening is present. Abdomen is mild distension is present. It was not irritable.
So good. So you said pallor, which is obvious. Wrist widening, when it is very marked, then only you talk on inspection. Otherwise, you have to confirm after palpation. Okay. Then abdominal distension. So this is a 1 to 2 year, that age group. So normally, do they have a pot belly? Yes, they have a pot belly normally. And therefore, you don't know. So you'll have to say, I will have to make him lie down and then see whether this is abnormal abdominal distension. Okay.
Abdominal distension has to be seen lying down. And how do you know that? If abdomen is going above the chest level. So normally, that is abdominal distension, which is pathological. If, if there is an obesity, abdomen looks big, but when you lie down, the chest is above the abdomen. So that's the way to go.
Okay. What is the interaction of the child?
Not very much lethargic. Just, mm,
Is she looking at everyone? He is looking at everyone. Interested, right? Yeah.
when he's not coming or like
It's fine. I'll tell you reason why that interested is important. You mentioned that the hair is sparse, which you are thinking in terms of what? Are you giving that some importance that the hair is sparse?
Kwashiorkor hair is
Very good. In Kwashiorkor, hair is sparse. But in Kwashiorkor, what is the behavior?
irritable.
Or more importantly, textbook picture. Kwashiorkor, what is the behavior of the baby? Apathy. So apathy means I don't care. Here she is interested in everybody. So you go back and say that this is not due to Kwashiorkor, the sparse hair, right? So then you'll have to ask the mother, how is the hair from the beginning, right? And that's the next thing. On history, you got. But now, do you think this is stranger anxiety? There are six strangers here and it's not crime.
He does not grasp it. We, we have a mess.
So this is very gross. What you are checking is extremely gross. Okay. So now, as doctors, we must know that hearing is at different frequencies. Mm. So your big loud sounds, your loud clap and your bell and all are low frequency. Then you have high frequency. And there are so many variables. So you have to do better testing than just that, right?
But I think the anti-consensus fuse, does that mean anything? Like it usually fuses by 18 months.
Always close.
There is an antifontanel. It's small, but it's not fused. Okay, so it's still there, and that can be consistent with this age.
Sexual power is different. Harassment fine नहीं है मतलब sexy भी thing नहीं है पर anthropometrically anthropometrically
What is the subcutaneous fat like? Adequate or wasted? Adequate. What is the muscle mass like? Very much affected or reasonably fine? Reasonably fine. So where is malnutrition? There is no malnutrition. No calorie malnutrition, no protein malnutrition, no edema. Muscle mass is fine. Behavior is fine. Okay. Subcutaneous fat is there, cheeks, everywhere. So where is the malnutrition? And our diagnosis is nutritional deficiency. Okay. But not calorie protein. Okay. It could be iron deficiency or whatever. Okay. So make a note of that. This was 1 kilo child. He's well padded, well padded. Okay. Muscle mass is good. Subcutaneous fat is good. So no malnutrition. Okay.
काम management हो गया है 14 days of काम
In 14 days, how much weight would this child have put on? Huh? So per day, how many? So this is not a result of that, right? But anyway, forget all that. We are learning. So in an exam, you must learn to answer these questions the way sir said. That subacute fat is good. You already said that earlier.
Length, all this together. His weight may be low because he's smaller. But because he's small, then what looks all right is is because of the weight. So what was length? Sorry, what was his length? 60 centimeters. 64. So 64 is like 4 months, 5 months. So 4 5 months child. And then what is the weight? It's not too bad. That is why he's not looking so bad, because that if he was 12 months, consider a child of 70 centimeters and 5 kilos distributed over 70 centimeters and 5 kilos distributed over 60 centimeters. The appearance will depend upon that.
But because he was 1 kg at birth, he would not be 50 centimeters at birth. He would have been much lesser at that time only.
243, as low as that.
This weight for this age is because the length is small, therefore this weight does not look, the diet doesn't look so undercut.
The point to understand is that, like Sir said, imagine that he was 43 when he was born in length instead of 50. So if he is put on 21 centimeters in 14 months, which is pretty good because 25 in the first 1 year. So something like that. So this is the way you have to analyze all this. Okay, from where did you start? The starting point also is important. No?
Nice few years for almost 1.5 months. So probably when he was discharged, he was not very good in weight. Also. That 1.5 month also, yes, which is the maximum gain in weight.
What is your comment on? So nutritional deficiencies, not BM, other iron, etc. Fat is fine, but you have said nutritional deficiency with developmental delay. So my question is, does nutritional deficiency lead to developmental delay? Suppose this child was severely marasmic, PM, kwashiorkor, would he be delayed development? Answer is no. The brain is always spared. The weight is gone, height is gone, fine. Well, there could be a minimal defect in terms of learning disabilities, but not developmental delay. Okay, so nutrition never causes developmental delay, right?
Any other abdominal findings you have for us to check? No, nothing.
Taking IV with. Why does he have an IV? Cough, I also have a cough.
On general examination on arrival, the general condition is fair, a febrile heart rate of 125 per minute with a respiratory rate of 28 per minute, with a saturation of 99% and CRT less than 3%. Peripheral pulse is well fed, extremity is warm, pallor was present. There is no cyanosis, clubbing, edema, or lymphadenopathy. Anthropometry wise, the child weight for height is less than weight for height is bit upper arm circumference is less than 12.5 centimeter. Is an impression of Sam, and child also head circumference is less than -3 and microcephaly is present according to the anthropometry. Head size is 41 centimeter. Head to toe examination, AF is open, sparse hair.
Is there a way to correlate the head size with the length of the baby?
Dines formula. Uh, which is length by 2 plus 9.5 plus minus 2.5.
Valid till what age? One year of age, right? Now this baby was premature and all and is now 14 months. So we might just stretch it maybe. So think and now tell me, is this head 41 okay for 64 or not? Do it, do the calculation. 64 na be length. 32 plus 9.5 is 41.5. Plus minus 2.5. This child is 41. So it's absolutely normal. And that is why visually when you saw that the baby looked proportional. Feel the head was too big or too small or something, right?
Systemic examination, respiration system, air entry bilaterally equal, no evidence of any crepitations, but abdomen soft, non-tender, and no hepatosplenomegaly. CDS S1 S2 heard, no murmurs heard. CNS tone is normal, power is 3/5, reflexes 2 plus. Uh, Lab investigations, CBC from the outside hospital showed HB of 3.9 and hematocrit of 15.1, following which the blood was transfused. CBC here showed HB of 8 with a hematocrit 30. RFT seroelectrolytes were normal. Even calcium was normal in here. USG was normal, 2D echo was normal. Summarizing, 14-month-old girl child, case of not gaining weight, complaints of not gaining weight, immunized till date with global development delay, with no significant past history, is most likely a case of SAM with GDD.
Why did you get two children? How you code it? Always preterm?
Yes, first child was preterm, 7.5 months. Second child, she's telling it was term child. So that's why इसका might it would be some other metabolic cause. So so people have told to do metabolic workup. So last it was quite elevated. Otherwise, so MRI was done today. And when neuro people said there is kind of developmental delay in the child. Uh, Even neuro the call, they said that delay, global developmental delay present. But as we are correlating now, I feel there is no delay as such because uh, preterm, because of the preterm.
Oh, so see, we are mixing up two, three things. So first of all, that prematurity is not supposed to give you any big delay today at 14 months of age. That's the first thing to understand. Okay. Second thing is that if you look at 14 months of age, then the delay is in motor is very striking. You're saying that the baby is just not sitting with, only sitting with support. So it is striking. Sir's point was that malnutrition does not cause delay. So we are not saying that there is no delay. There is delay, but you can't attribute it to malnutrition. So we'll have to find some reason for it, right? And with those two deaths, you can't call both of those deaths as accidental. So we'll have to keep our antenna up for something that is related. Okay. Though the progress of this baby is not very obviously like a metabolic disorder which has come up in a big way, because they would come up in infancy and would be sick and all that. This baby is doing okay for that 1 kg weight at birth. Baby is not so bad. In spite of the fact that was only fed cow's milk, was not given complementary feeds, right?
A mother said that he has developed stranger anxiety, which is about 6 months or so. After that, judging his developmental milestones was difficult, but I tried peekaboo, which would come at 8 months. He was nowhere near peekaboo. He was continuously staring at me for 20 minutes, whatever he was. He was looking around, but he was not very anxious about, but she said that he doesn't go to everybody. But so somewhere between 6, 7 months will be his development period, considering that's what he term 1 kg. So developmentally, he is like 6 months. And growth wise, if you consider, is not that bad considering. So his growth is better, but developmentally, he is not all that good. We'll have to see whether he's actually better. Something at least caught up by 1 year. And
Have you looked at hearing any evaluation?
The evaluation here OA was not done, but इधर का जो evaluation से normal बोला है but autism क्या नहीं है hearing पर
Evaluation as in just examination of the ear is not going to tell you anything. You have to formally evaluate the hearing, right? And that should be done.
you call him by his name, does he look? Don't stand in front of him and call, but by side and if you call, does he look? Ask the mother whether आप उसको नाम से पुकारे तो देखता है, but it's difficult to say yes because he may be responding to um, voice rather than to his name. Okay.
Comment that another common cause of such a delay is the lack of stimulation. This baby is 1 kilo, socioeconomic group. Okay, who will stimulate this baby? And one thing that unless there is a stimulation to the brain to grow, the neuronal development does not occur. Okay, which is taken for granted in an average family, but in this family with such a small baby staying in the hospital for first few weeks, there is no infant stimulation at all. So all that has happened is if there is not enough stimulation, this child is likely to lag behind a little, but now must be well stimulated. Somebody must be, of course, considering first that there has been done and there is no hearing problem. Somebody must keep on talking to this baby, playing with this baby, handling this baby, making the baby see something, play with the toy.
Even in the house.
And if they don't do that, then this child will be lagging behind for no reason. The brain is not abnormal, but there is no stimulation. And I think that is the most common cause. In an examination in our setting, you will always get such a child who would be a little delayed, and the discussion would go on whether it's something pathological or something environment. And I think environment is certainly contributory. Being a preterm baby, we don't know whether bilirubin was high. Okay, we have no idea. Then we don't know whether there was some episodes of hypoglycemia which went unnoticed. Child is on IV. So possibly these are, but surely there was no hypoxic ischemic encephalopathy. The child did not need much oxygen support, but hypoglycemia is pretty common. And if he's not fed for 6 hours, that blood sugar dropping down is good enough to cause a brain problem. And again, which part of the brain is involved in hypoglycemia? Any idea? So,
one is the occipital lobe visual cortex. Okay.
Hypoglycemic occipital pulse and bilirubin basal ganglion hearing. Okay. But hypoglycemia is pretty common, undiagnosed, unknown, and the child comes slowly with delayed development. So these are the probabilities.
Which will, yeah.
So the first child and the second child also they died like within 1 or 2 days after birth, and then the this child is also preterm. So maybe can it also be because of like any metabolic or any neurology, sorry, any other condition?
To keep metabolic disorders in mind. Yeah? Okay, thank you. We'll stop here. Any comments or questions from the online audience? Any?
No, none. Rajesh, we are deeply grateful to Dr. Amdekar for taking this trouble and the whole team, Dr. Khare, for presenting these cases and the discussions to us. And we are also thankful to the children who presented today. And there were more than 7 practicing pediatricians online. And we generally get more than 100 YouTube views later.
Yeah. Thank you. Thank you, Anjali.
And
Thank
the thought process is really the sir's thought process and your people's thought process. Only the people who are daily seeing the patient in and out knows the importance of this thought process. Really amazing thought process. Really, it's a great tonic for us.
Yes, absolutely agree. Thank you very much, sir.
you. Thank you, Anjali. Thank you, Palni. Thank you, everyone. Oh, thank you. Thank you. Bye.
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 Oh, I've uploaded it. Huh? No. To our clinic, practicing clinic is coming on. I just confirm. This appointment will come. Thank you. Sure. So, since you all are in, you find it useful. So get your friends. Tell your friends also to come. Yeah. People, huh? From the class. It is a good learning exercise for it. Okay? Thank you, sir. क्या और तुम्हारा नया बैच ज्वाइन किया क्या? सर एक्चुअली वी आर ये फ्यूचर बैच क्यों वो नया बैच करता हो? नहीं सर कोई पर्सनलिस्ट आया कोई ज्वाइन नहीं किया एंड बैच में we two people are there and we are actually नहीं तो वापस ट्वाइस क्या बोलते हैं फोर्टनाइटली करना है कि यू गेट न्यू पीपल See, देख एकदम frankly, सर को तो बुरा लगा हो तो natural. He put so much effort, so he will feel. He, let us be practical. हमको भी मालूम है कि but फिर एक दो जन के लिए हम लोग को भी और लगता है तो भी क्या solution? Alternate week करना है तो वैसा बोल अगर मतलब I'm just thinking aloud so you tell me. Is it कि ट्यूसडे को पता चलेगा कि ये थर्सडे कैसा होगा? Is that a possibility? What I'm asking is committing from today or next Thursday. You don't know how much is the workload. Would you know only one day before or you can know 2 days before? 2 days before. If I'm just imagining, can we take a call every Tuesday कि ये Thursday को and day after tomorrow class है कि नहीं, depending on work. Is that a possibility? कि if you can say on Tuesday कि अभी थोड़ा better है, so this Thursday more people can come. Is something like that possible? कि Tuesday को भी नहीं मालूम पड़ता, Tuesday को मालूम पड़ता है. So I'll ask sir if can we then do that, because see I understand अभी अगर अपन if we commit के alternate Thursday suppose we say, but that alternate Thursday if you have too many patients, too much work in the wards, then again you will not be able to come, correct?
much of our residents were
एग्जाम भी चालू हुआ है.
एग्जाम, हाँ सर अभी एग्जाम भी है एंड अभी 29 से हम सीनियर बैच का एग्जाम भी है. So many of our batchmates and juniors have fallen. Some of them have fallen sick, some have gone for CME and conferences. So that's why
Those who don't come, we will see online later.
yes, they do. Yes, they do. If it is not possible for anyone to come, people see it.
और एक दूसरा क्वेश्चन था, do you have friends in other medical colleges? Means I'm saying your batch, like now you are a junior, you're a first. So your batch में से who took pediatrics? I'm saying in general. Somebody must have got at JJ, somebody must have got at KEM. Possible or not? From your batch. So nobody from your is here. I'm just asking, okay, what is their scene? Why are they not participating or joining? You are local. तो तेरे बैच का जो दूसरे कॉलेज में तेरा कोई फ्रेंड है पीडियाट्रिक्स में कि नहीं? और ऊपर में है. तो I'm understanding. मैं ये नहीं बोल रहा हूँ कि उसको बुला. I'm asking कि वो लोग बाद में ऑनलाइन ही देखते हैं ऐसा. ट्रैवल मुश्किल,
ट्रैवल डिफिकल्ट बट ऑनलाइन
तो ऑनलाइन सपोज लोग अगर लाइव ज्वाइन करेंगे लाइव, तो जैसे अभी तुम लोग इधर 2 जन, बट सपोज 10 जन ऑनलाइन, तो जो क्वेश्चन हम तुमको पूछ रहे हैं वो हम उनको ऑनलाइन भी पूछ सकते हैं, पर वो ऑनलाइन भी नहीं आते हैं ना, वो टाइम पे बाद में आते हैं, सीट लेटर. तो लाइव अगर ऑनलाइन हो तो वी अंडरस्टैंड कि ट्रैवलिंग और टाइमिंग का कुछ और भी चेंज करनी है. 5 to 7 is okay. 5 to 7 is okay. Afternoon is not more free or anything. I'm asking. Not saying we want to come in the afternoon. I'm asking. Is it more free? Afternoon.
हमारा वार्ड पीरियड सब खत्म होने को 4-5 बजते हैं कि नहीं? Those who are admitted, IV लगाओ, ये करो. राउंड कितने बजे खत्म होते हैं? 12.
What are OPD times?
OPD is 9 to 1.
9 to 1. So
Specialty OPDs then afternoon OPDs till 4. Some OPDs go till 4:30 and 5 o'clock.
fine, but from your general pediatric OPD, which is 9 to 1,
9 to 1.
most of your admissions come from that OPD.
Yes. Some come from yes. It comes from that.
On an average, every emergency admissions are in a day, including regular OPD and DC. How many admissions in a day?
Currently, around 10 to 15 admissions a day.
And you have 3 units?
4.
So your emergency day comes once in 4 days?
Yes, sir. Almost once in 4.
emergency and OPDs.
OPDs on the emergency.
Emergency day.
General OPD is on the emergency day, and every unit has a specialty OPD.
That in the
Yes, sir, it is in here.
so you have general OPD once and one or two specialty OPDs in that. No, so what I'm asking कि जिसका आज OPD है, Thursday OPD वो यूनिट को जाने दो, but जिसका Thursday OPD नहीं है, वो Wednesday और Tuesday OPD वाले लोग, what time of the day do they get? That's what I'm asking.
So OPD usually 4 o'clock तक it gets over the afternoon OPD. But
जिसका Wednesday OPD था और Tuesday OPD था, उसका तो आज OPD नहीं है, उसका तो अभी बैच में बात करके tell me one main thing is tell me के instead of predicting every Thursday or every alternate Thursday, which I can understand, you don't know that Thursday का scene, but can you know that scene on Tuesday? If yes, then we'll make it a habit. We'll declare every Tuesday only whether this Thursday there is a class. Correct? But if you can't predict even on Tuesday, then we'll have to think of something. Because declaring on Wednesday, okay, tomorrow there is a class, for us that is also okay, but it becomes too close.
no, so that will become very clear.
And by any chance, any other weekday makes a difference? Yeah, won't be push for it. All weekdays are same. Only Tuesday, Wednesday. Same.
Yes, sir.
Sure. Sure. Keep all this अच्छे से.
You are